Good morning, Honorable Organizing Chairpersons and Organizing Secretaries and all the office bearers of ISAR, IFS and ESHRE. Many congratulations for this confluence and a beautiful conference. Thank you so much for giving me a very good topic actually today, because to my understanding, this topic can change our doctor's practice in a fertility clinic. So I'll just begin very quickly by sharing the basic video of an office hysteroscopy. Here we are entering through vaginoscopy. We entered the cervix and now we have entered into the uterus. Saw the panoramic view first. Now we are seeing the right ostia, the left ostium, and then back, and then again the panoramic view of the cavity. And in this day and age, this is actually the minimum that should need to complete the evaluation of, for example, someone like an unexplained subfertile couple. In this particular presentation, I am really focusing only on the actual ambulatory settings, meaning in the doctor's office or in a procedure room, not in the OR, not in the operation room, and without anesthesia. The patient is awake, can follow the procedure. There's no anesthesia or maybe just minimal analgesia, no speculum, of course, and just some vocal local. This is a very, very good guidance issued by Royal College of Obstetricians and Gynecologists for the office hysteroscopy. And I have just summarized in a few slides this guideline before I share some more. Opiate analgesics are to be avoided. NSAIDs can be used. The installation of anesthetic local into the cervical canal does not reduce pain, but for a woman who has had history of multiple vasovagal reactions in the past, for those women, we can use this. Especially when we're using the tenaculum in a particular case, we can use a topical local anesthetic. We really need to focus on the size of the scope that we choose for the office hysteroscopy, because the diameter of the whole system, with or without operative sheath, if the operative depending on what we're doing, the diagnostic or operative. So even if you're doing operative together, everything should not cross 5 millimeters if it is the system used in the office without the anesthesia. Cervical preparation with misoprostol is advised that it should not be used because there is no benefit in terms of pain, in terms of rates of failure, or the uterine trauma. The service provision is as given in the slide. All units actually are advised to have it because there is an obvious and clear clinical and economical benefits to the patient, to the whole healthcare system. For example, we're not waiting, for example, especially in the bigger hospitals, we are not waiting for we're not making an oncology patient wait and piling up the polypectomies, because these are simple procedure and 60% of them can be done in the OR, especially when we're talking of the fertility couples. The indications, especially when we are transitioning and just starting to do it without anesthesia, then we can start by doing the diagnostic ones. Especially these days, we have handheld, portable, mechanical, without any electrosurgery, without any separate light source. Those kind of diagnostic or directed biopsies can be at least the procedures that you can begin with, and then you can do the rest of them mentioned in the list. There is no standard size. So for example, what is the maximum size of the polyp or the G0 myoma that you can take out? It really depends on the skill of the surgeon, the experience, and the proper knowledge of the equipment. Anything that can be finished within 15 minutes based on all of these, especially the skill, you can do that. There is deliberately no number, like, for example, say 4 millimeters has not been put 4 centimeters has not been put as the threshold of a polyp, because it actually depends on the skill of the doctor. Some people need more time, and some people can really complete that within that time. So the time is more important, because office procedures cannot be longer than, say, 15 to 20 minutes. Conscious sedation should not be routinely used. Vaginoscopy should be used, especially when you occlude the labia. It helps and aids the scope to enter the cervix without you actually putting the speculum inside. Now, here we complete the guideline summary, and then we do some other discussion. So these are the examples of those cases where office hysteroscopy obviously cannot be used. So the patient selection, simple cases, small polyps, diagnostic, directed biopsies should be the one based on which we can actually convert the in the beginning, convert some cases who don't need to wait for the ORs, and actually, especially the travelers who come from all over the place to a particular fertility center, you can do office hysteroscopy for them. Yes, so this actually highlights that we need to break away from a certain state of mind, and then transition always needs a different thought. The pressing indications, as I already emphasized earlier, that small polyps seen in an aqueous scan, or a little flappy endometrium which you think is a polyp, or anything which is unexplained, these are the cases where really there is no need for the patient to go in the OR if the doctor can perform office hysteroscopy. So really this actually can change your practice. The types of hysteroscope, there are many. Very important part is the diameter, 2.7 with 3 to 3.5 mm sheath. These are very commonly used. Obviously, we have both 0 degree, 12, 25, 30. And the angled hysteroscopes definitely are very, very good. But there is another side, that when we use the rigid hysteroscopes, and most of the angled ones are rigid, there are other problems. So when you're doing the office hysteroscope, maybe flexible has a better place, at least in the beginning, because of obviously there is less pain. Obviously, it's the choice of the surgeon and how well the patients are taking your particular style of office hysteroscopy. So distension medium in this setup is normal saline. It reduces the vasovagal episodes. Image quality is better. It can be done quickly. Bipolar also can be used in case you do, but most centers don't use the electrosurgery as long as office hysteroscopy is concerned, but of course it can be done. So rigid can cause uterine contractions like this image, and flexible is actually like a cooked pasta, which is softer. And obviously think of yourself and just imagine something going in, and definitely something softer and flexible is always better. And with trained eyes, it actually is equally good, especially with these days we have fantastic resolution. Obviously, in the office hysteroscopy, the patient is awake, so dignity, gentleness is the key. Obviously, when we are starting, definitely cover the tip of your hysteroscope with the finger till you actually start the vaginoscopy, because definitely no one wants to be putting someone's private parts on the 50-inch TV with a high resolution. Vaginoscopy should be done. Speculums should not be preferably put. If they can be avoided, they should be avoided. We can keep these two numbers in our mind when we choose the hysteroscope, that the average nulliparous lumen is 2.7, the average parous lumen is 4.2. Definitely the history of any previous surgical termination of pregnancy or things like that will allow a little bigger size of hysteroscope. So this is a hard-on slide in which I've put all of the hysteroscopes together, which can be easily used as office hysteroscopes. Now, in these, if you see, a very easy handheld, thin, not very thick diameter is Endo C. These days getting very popular. We'll see some pictures of how it works. And definitely there are TrueClear and MyoSure, which are the tissue removal devices. Um, this is a paper in which actually this is emphasized that there is no significant difference that exists between the pain scores when we compare the experience after the mechanical or the electrosurgical polypectomy. Now here we see that something that is thicker in diameter, it can occlude, and this will not let your procedure finish in the office because this will cause massive pain to the patient. When we choose the diameter carefully, when it is not very thick and not completely occluding the canal, then the pain is less. You can take those 15 minutes to actually complete your procedure, and then the time of this procedure is the key to the success. That will avoid you going in the OR for a repeat procedure. This is another one which actually shows that for an angled hysteroscope, if you raise the camera right like that, you actually make it a better entry. Mechanical instruments are better used for the biopsies, adhesions, septae, small polyps, and then slowly when things are bigger, you can definitely use the resectoscope. And like I said earlier, it's not the matter of time, it's the matter of time, it's not the matter of the size, it's a matter of the skill, how early you can do, and then how early you can do and what size you can do. Hysteroscopic tissue removal devices are TrueClear and MyoSure, and the disposable devices are for something like EndoC. Uh, these are the differences. This is a study which is actually not done by anybody else and only done by Stefano Bertocci, which is actually based on the pain score. And the results are very encouraging that if gentleness is the parameter followed, and if the surgeon is skilled, then pain will not stop you in most cases. Common complications are, of course, pain, infection in 1 in 400, perforation 1 in 1000. But when we know the equipment well, all the common complications really go low. For a subfertile couple who has come for an initial consultation, we do the questionnaire, we do the scanning, and then we do the semen analysis. But of course, even in trained eyes, scanning is having subjective variation, plus scanning can have errors because it is actually sending the ultrasound waves, creating an image, and which can have errors. So the real gold standard we all know is actually to go inside the uterine cavity. And if we have some instrument, a toy in the hand, in the office, which we can really easily use with less cost, definitely that will change our practice. And that is what we are talking about today. This is something that I am actually referring to. This is a handheld portable device. There is no separate light source. It's like a mobile phone with a hysteroscope. So it's very easy. It can actually change the practice, meaning decrease the cost to the patient because it's a simple procedure, doesn't need the anesthesia, doesn't need to be going into the operation theater, and it can be used at least to begin with even before going into the operation room, or at least as a diagnosis, especially in an unexplained cases. For example, we all see that years and years the patients are thinking that their case is unexplained infertility, and they're doing acupuncture and all sorts of other helps. But when after many years, when someone actually goes in the uterus, there's a polyp sitting, or there's some pathology which was not seen, because at the end of the day, a proper hysteroscopy is actually a surgery. So everyone is um, definitely not very people don't accept surgeries very easily, not all of them. So something which is less invasive, easy, even cheaper, will definitely allow them to make use of such technology. And 17% of the existing pathology can be missed if we do not actually go into the uterus and we use the other modalities of investigation. Plus there is color. We are actually really going in the cavity. There's a colored image. The resolution is fantastic. I've used it myself, and definitely better than the scan, and also not to be compared because it's a complementary thing to the scan. Scan is the first foremost thing, and then you can evaluate the cavity further with something like an endo-C. And that completes my presentation. And thank you very much to everybody for your time. Thank you.